Welcome to Continuing Education for Granville County EMS, January 2022. And I don't know about you, but up until 24 hours ago, I thought we would be doing this in person. And I'm certainly sad not to be able to do that. I do enjoy FaceTime and getting together with everyone. However, yet again, COVID strikes and we have had to make some changes. Specifically, we decided that it was not a good idea to have everyone get in the same room, given how infectious Omicron is proving to be. And we're actually going to talk about that in a few minutes. But, even if we were to all wear masks, given the amount of time we would have to be in that room and the size of that room, the potential for infecting other people would be significant, especially because we know many people are asymptomatic carriers. And, at this point, we cannot afford to have anyone get sick. As you are aware, many of your colleagues are on quarantine. Fortunately, people tend to be doing well, generally due to vaccination. But, when we have employees test positive, they cannot work, and that's having a significant impact on our EMS workforce, as you are well aware. Also, given the amount of people who are currently on quarantine, we realized that the attendance would probably not be as great as we want it to be. And particularly for this CME, it's very important because we are going to implement the 2021 protocols. And there have been some significant changes, particularly around ketamine. We are going to be using ketamine, and I'm very excited about that. But we need to do a very important CME around that. There's also been some significant changes around the behavioral health algorithms. And so what I'm going to do is actually divide this into two parts. Video 1 will be ketamine. Video 2 will be behavioral health. Most of the other protocols have stayed the same. There are no other real major changes. But before we get into either of those, I actually would like to spend a few minutes talking about COVID, just so that you have knowledge. I believe knowledge is power, and I want to give you a sense of what's going on right now in the Granville community. So, what is going on right now? Well, I don't think you need me to tell you that we are in the middle of a massive COVID surge, and this is primarily due to Omicron becoming the predominant strain in the United States. It is now certainly the predominant strain in North Carolina and has been since probably about mid-December. And not surprisingly, we are seeing a massive spike. You can see in the graph here, this is the graph for the United States. However, if you look at the North Carolina state data, the curve is basically exactly the same. We're diagnosing far more cases on a daily basis than we ever have. These last few days in the United States, there are more cases per day than at any other time during the pandemic, including last winter's surge, as well as the surge we had this September, October. So that is very significant. And we are seeing that here in the triangle. So, as you know, I work for WEPA. We are the emergency group that covers all of WakeMed as well as many other facilities. And so I see the data for every ER for every day. And across the entire system, the ERs are operating at 130 to 190% normal volume. And certainly this is true at Granville. So at Granville this last weekend, I worked Saturday and Sunday. And typically, a day for us, a weekend day for us, usually averages in the 60s, somewhere between 60, 70 patients in a 24-hour period. Since the week after Christmas, we've been more in the 80s or 90s. So obviously that's a very significant percentage increase. And virtually all of those patients are people coming in either with COVID symptoms or requesting COVID testing. And that's, of course, in addition to the people we were already seeing for COVID symptoms. I kept informal track this weekend, and literally just over 50% of all ED visits were for COVID testing or COVID-related symptoms. So, that is a very large number. Now, we saw probably around 170 people this weekend. Roughly half of those, somewhere around 80, 85, were for COVID-related care. What's amazing is the percentage of people who are testing positive. So all these people who are coming in with flu-like symptoms, fever, chills, or people who are coming in saying, my daughter just tested positive and I want to be tested. The positivity rate, at least for me this weekend, for my patients, was approximately half. And that is obscenely high. So just to put that in perspective, we consider anything above a 5% positivity rate to be a high level of transmission. The goal for the United States is to keep the positivity rate below 5%. At the peak of Delta, last winter and this fall, when we had those huge spikes, we would see positivity rates of about 25, 30%. Now we are seeing 50. So that is unbelievably high. And that just gives you a sense of how infectious Omicron might actually be. And we're going to talk about that in a second. But let's just stick with Granville for the moment. Keep talking about this weekend. So again, 50% positivity rate, that means around 40, 45 patients actually had COVID. And if we break down the numbers, about 3 of the patients we saw this weekend were critically ill, requiring admission, requiring significant intervention, very high probability of dying. 2 of them certainly, I think, are inevitable deaths, and, the third one may not do okay. Then we had about 8 people who were very sick. These are people who did not have oxygen requirements, but otherwise, under normal circumstances, we probably would have admitted to the hospital, but we are not doing that now because capacity is so strange, so we're sending these people home. They're miserable, they're not eating, they're not drinking. And these people do have the potential to become sick. These are the people who are going to have long cases, 1 to 2 weeks, and we know that a lot of people get sicker around day 8 or 10, and so these people certainly may come back critically ill. Then we had about 20-ish people with just sort of your mild, moderate symptoms. I feel crappy, cold, flu-like symptoms, maybe throwing up. And then we had actually around 11 people with no symptoms. Now, what's interesting if you look at these numbers is, well, what percentage of these people were vaccinated? So then that's what those numbers are on the right. So none of the critically ill patients were vaccinated. None of the very sick patients were vaccinated. About 2/3 of the patients with mild to moderate symptoms were vaccinated. And then virtually all the patients who had positive tests but no symptoms were vaccinated. So this just kind of tells you, right? I mean, it's pretty obvious. It's self-explanatory. Vaccination works to prevent severe illness. And that data has been shown time and time again. So let's talk a little bit specifically about Omicron, because things have changed and it's important to know how they've changed. So Omicron is definitely much more infectious than the Delta strain. It's probably about 3.5 times more infectious. And you can see that this graph, which is data from South Africa, which had some of the earliest Omicron outbreak, you can just see the rate of acceleration, versus Delta, Beta. It just grows at a much more rapid rate. What's a bit unclear is it less virulent, meaning less deadly? So we are seeing a lower percentage of patients hospitalized. That is true. But it's been very hard to determine why that is, because a lot of things are different in the community, right? There are many more people who are vaccinated, even people who historically have not worn masks or not taken precautions are now taking many more precautions. We also have a lot of mandated mask wearing, particularly in other parts of the world. And so it's hard to know, is that what's resulting in less hospitalizations, or is there something actually about Omicron that makes it less virulent? And the truth is probably somewhere in between. But it's also important to know that because Omicron is different, there are a couple myths floating around out there. And this is the last thing I'll say about Omicron is, I want to dispel these a bit. So this idea that Omicron is much less deadly or not deadly at all. Not true. Again, it may be a little less likely to result in hospitalization, although I have to say one of the big things that came out just a few days ago is that in the US, the hospitalization rate is not that much lower. Other countries seem to be experiencing less hospitalization with Omicron. but we are not. And to be frank, other countries just have much better public health measures, much more mask wearing, much more testing. They're basically, across the board doing a better job. Unfortunately, the data thus far is not showing that our hospitalization is being that much affected, for example, being that much lower than what we saw with Delta. And so that's a little concerning, and that's in sort of a story that continues to unfold. Related to that myth is this other myth that everyone who's hospitalized is hospitalized not because of Omicron, but they just happen to have it. They're all going in for hip fractures and appendicitis, and they're getting tested, and it just so happens they have Omicron, and that's driving the numbers up, and that the numbers are artificially high. Also, that does not appear to be panning out. So yes, of course, there are patients who get admitted to the hospital, and we test everyone who gets admitted, and sometimes we're surprised. We do admit someone for appendicitis and come to find out they also happen to be an asymptomatic infection. But that was true with Delta and Alpha and every other variant. Is a larger percentage of people who are hospitalized, is that happening to them? Are we finding sort of more asymptomatic infection? And it seems like yes, we probably are. But even if you adjust for that, even if you remove that from all the data, the amount of people being hospitalized right now is still much higher than other surges. People who are being hospitalized because of Omicron, not just happen to have Omicron. So, there's certainly among certain political circles this myth that, these hospitalizations, they're all asymptomatic or minor infection. And that's just not true. Also, on another level, it doesn't matter, because when someone breaks their hip and they get admitted to the hospital and they just happen to have Omicron, they still have to be in isolation. They still have to be in specialized rooms. They still have to have special nursing assigned to them. And so these patients are still taking up huge amount of resources and putting huge strain on the system, even though their reason for hospitalization may not be Omicron. And so it's still a problem that those people are being hospitalized, and that is why you hear about the healthcare system collapsing, because that's what's causing all the strain. So, another myth, prior infection protects against reinfection. Also not true. This has been what a lot of people have argued, and a lot of lawsuits against employers have been based on this idea that you should not force me to get the vaccine because I've already had COVID. Well, we've sort of always known that probably wasn't going to work out. And now, particularly with Omicron, prior infection with either Alpha or Delta or any other variant does not seem to be giving a lot of great protection against reinfection. It may make your reinfection less, although we are still seeing, and I have to tell you, I saw people this weekend who were significantly ill despite the fact that they had been infected before. The vaccine provides better protection against more strains. And, that's sort of common sense epidemiology. The vaccine is designed to react to parts of the virus that are unlikely to mutate. Whereas when your body gets infected with COVID, you make antibodies against a whole bunch of different parts of the virus, and many of those may mutate. And so what we're seeing in particular is people who were infected, particularly early on, like the first year of COVID, are not having that much protection against Omicron. And then the third thing I will say, which is important, is this idea that masks don't work. So there's definitely this idea out there that surgical masks, because Omicron is so infectious, surgical masks like the 3-layer masks and the cloth masks just don't work as well. And so we might as well give up, right? We just should stop wearing masks. So it is true that cloth masks and those like loose 3-layer surgical masks probably are not enough. Omicron is particularly infectious. But, KN95s, and certainly N95s, but KN95s, which you can get now in almost every pharmacy, every store, still provide very significant protection. So I'm telling you all this because, again, as people in the community, you are looked up to as a educated healthcare provider, and people, family members, friends will ask you questions. And so, I hope what you take away from this is encourage everyone to get vaccinated, even if they've had previous infection. If you're not vaccinated yet, I hope you will consider it. Keep in mind, 3 shots is now considered complete vaccination. It's pretty clear that the booster is necessary. So, a lot of people are getting the first 2 shots and then sort of not caring so much about the booster. So if you are eligible for a booster, make sure you get it. And consider upgrading the masks that you're wearing. If you're not already wearing KN95s in stores, if your kids are not wearing them to school, strongly consider using them. So that's my brief spiel on Omicron and what's going on in the county right now. Any questions, please, of course, feel free to reach out by phone or email anytime. I'm more than happy to address any concerns or questions about Omicron, vaccination, or anything else. So with that said, let's jump into our CME. So as I said, ketamine and behavioral health, those are going to be our 2 major focuses because those are the 2 major updates in the 2021 protocols. So we now have ketamine. I am very excited about this. Ketamine is one of my favorite drugs, and I hope you will understand why by the time we go through this. It is a fantastic drug for sedation, as well as a pretty good drug for pain management. Also, there has been very significant changes to the behavioral health algorithm. So the behavioral health protocol is now really 4 protocols with a bunch of different options and things that you need to know. So we are going to go into that as well. So I want to begin by talking about, sedation drugs in general. And, unfortunately, we're not doing this as a group, but right now what I would do is I would ask all of you to start shouting out some ideas about what do you think the perfect drug for sedation is? How would you want it to work? Would you want it to be fast, slow, short acting, long acting? Just take a moment and reflect for yourself. What are the ideal properties of a perfect drug for sedation? And, generally, if we had sat down and brainstormed, I think we probably would have come up with a list pretty similar to this. So, in the pre-hospital setting, we want drugs that are fast acting, right? We want them to be reliable in their dosing, and this is one of the problems with Versed, for example. You can give 5 IM Versed to someone and completely snow them. You can give 5 IM Versed to another person who is the same size, and it barely affects them. What would be nice is if the dosing were reliable, that you could count on, 5 megs of this or 10 megs of that as having a consistent effect between patients. An ideal drug would reduce pain perception. It would reduce awareness. It would provide some amnesia so people don't recall the events. You generally want it to make people immobile. You don't want people flopping around, right? So you want a drug that just kind of keeps them from moving, makes it so they don't remember, good pain control. The other things we probably want are really good hemodynamics. And this, of course, is the problem with virtually every drug we have, whether it's etomidate, Versed, they all have negative effects on the hemodynamic system as well as the CNS. So, for example, almost all of our drugs drop blood pressure, which, is not necessarily a good thing if you're in the field and you have a trauma and they're already hypotensive. They reduce brainstem control over respiration and airway maintenance, right? People lose airways when you sedate them. People start choking, aspirating their secretions when you sedate them. People start throwing up into their own airway when you sedate them, right? And this is true of virtually every sedating drug. Other things we would want, we'd want this drug to be cheap, and given, limitations of EMS, we probably want a drug that does not have to be refrigerated, right? And so, this is a short list of what perhaps the ideal sedating drug would look like. And people have been trying to create this drug for decades, and probably the first close drug that anyone ever invented was phenylcyclohexylpiperidine, right? Which is just a very mouthy way of saying PCP, right? So PCP was synthesized in the 1950s, and it was made to try to create an anesthetic drug that had these properties that we just mentioned. And it worked. PCP actually in high doses provides great pain control, great anesthesia. It creates amnesia. It makes people immobile. It does all, and it's very hemodynamically stable. But one of the problems with PCP that they started realizing very quickly when they started using it on humans is the psychedelic and dysphoria effects. So one of the things that a lot of people complained about when they were given PCP is they would feel like they were floating in space. They would start hallucinating. They would start feeling like their arms and legs were no longer attached to their body. And this kind of sounds fun, except it wasn't fun. So a lot of the people, these weren't positive experiences. A lot of people were very distressed by these experiences. They would also, as the PCP started wearing off, they would get very hard to control because they would start to wake up, but they still could not feel where their arms and legs were in space, or they continued to hallucinate. And they became very difficult to control. And this is what we call emergence phenomenon. The other big problem with PCP is that it definitely lowered the threshold for seizures, and we saw a fair amount of seizures with it. So it looked good in the lab. Human trials, it didn't work out so well. PCP kind of fell out of favor, and then eventually in the 50s, 60s started to become a drug of abuse. But once you have a chemical that kind of works, like PCP, what you start doing is you start tinkering with the chemical structure and try to come up with something very similar. And eventually, in 1962, they came up with ketamine, which is a PCP derivative. So ketamine basically had all the upside, all the good effects, but much less sort of psychedelic and dysphoria effects, and also a much lower likelihood of inducing seizures. And so ketamine became popular very quickly, particularly in the Vietnam War. People started using it in the battlefield, and for all the reasons we mentioned on the previous slide about what the ideal drug would be, ketamine had most of those properties, and it was really good to use in sort of battlefield, pre-hospital type setting. But after the Vietnam War, it started to fall out of favor. One of the reasons is, again, there was some emergence phenomenon. As the drug wore off, people going a little crazy, hard to control. It was much more associated with PCP, but the sort of stigma was still there. And also, just like PCP, ketamine has a great potential for abuse. And in the 1960s and 70s, with the war on drugs, a lot of things like PCP, ketamine, LSD, a lot of these types of drugs, which, in certain settings have very legitimate medical usages, started to be classified as drugs of abuse. And so what really happened with ketamine is it kind of disappeared into the veterinary world. And so, for decades, veterinarians have been using ketamine extensively. But it wasn't until recently, at least in the United States, that we start seeing it reemerging for human use. But what's interesting is, while this drug was not popular in the US, it was becoming very popular throughout the world. So the World Health Organization maintains a list of what they call critical or essential drugs. And these are drugs that, every country needs to be able to do basic health care. And, these are usually generic drugs that, aren't very profitable to manufacture. And so, the WHO spends a lot of time focused on making sure that these drugs are easily available worldwide. And ketamine is one of their essential drugs. And this quote is taken directly from the World Health Organization literature. And basically what they say is, in many parts of the world, there's no choice. Ketamine is often the only anesthetic at hand. It's extremely safe because, unlike other anesthetics, it doesn't depress breathing or blood pressure. It means it's relatively easy to administer. It's great for patients who have lost a lot of blood or who may be in shock for other reasons. Ketamine's high level of safety also makes it unique among anesthetics because it doesn't require electricity to run a ventilator. It also does not require oxygen, and it doesn't even really require a high level of training to use it, so you don't need anesthesiologists. This makes it critical for surgery in low and middle income countries, and also in conflict and disaster zones where those resources are not available. So ketamine's a pretty unique and amazing drug for those reasons. And if you ever want to really learn how amazing ketamine is, I highly recommend watching a movie called The Rescue. So this is currently available on Disney+. It's a documentary about the Thai soccer team rescue that happened a couple years ago. And you might remember this. A couple years ago, there was a soccer team. It's like 10, 12-year-old boys in Thailand, and they were hiking in a cave. And this cave is safe to hike in most of the year, but during the monsoon season, the cave completely floods and becomes inaccessible. And these boys and one of their coaches, so there's 12 boys and one coach, were hiking in this cave. And there were these early rains, like the monsoon season came early, and there was a lot of raining in the area around the caves. And they didn't realize that the cave started filling up with water. And this is a huge cave, right? This cave is like 10, 12 miles long. And when they started to try to leave the cave, they realized that they were trapped. And they basically got trapped in this place to the left called, I think it's called like Puratur Beach. And that's about 10 kilometers or 6 miles from the entrance. And the cave basically flooded and locked them in. And so this was a huge rescue. It made international news. Every day it was on the news. Basically, there were hundreds of rescuers from all around the world trying to figure out like how to get to these boys and how to get them out. So basically what happened is almost every world-class cave diver, in the world came to Thailand to try to do this rescue because the skills that you need to dive in these caves are very unique. In fact, the Thai military, their Navy SEALs, which is where all their high-level divers are, they tried to move through these caves and swim and do rescues, and basically they did not have the skill set. And in fact, one of them eventually died, and it got to a point where the military would no longer allow their divers to dive during the rescue. So what you were left with is these volunteers, and these were just, extremely high-level amateurs, people who were cave divers on the weekend, and particularly a couple guys from the UK and Australia and Eastern Europe. These are people who just sort of dive for fun, but they are the world's most elite cave divers, and they were the only ones who had the skill set to even reach the boys. So when they reached the boys, they realized that they would have to dive them to get them out, right? Because it's a total of about 3 hours of swimming through flooded cave. And some of these passageways are like 18 inches wide, right? So you can only go through like one person at a time. And so what the Thai military and what a lot of the news agencies were told was that they were going to try to do something like this, right? You're going to have some divers, they're going to put some scuba equipment on the boys, and they're just going to swim them out, right? And this is what they told them they were going to do. In reality, what was happening behind the scenes is they realized that they could not take the boys out conscious. Because what would happen is, some of these boys could not even swim, right? So if you put them in murky water where you can't see more than 6 inches ahead in front of you, and you drag them through claustrophobic cave tunnels underwater with scuba equipment on, and they can't swim, like that is a recipe for disaster. And at one point during this rescue earlier on, there were actually some adults that got trapped. If we go back here, these adults got trapped in like this first pocket of water you see towards the entrance of the cave. And the cave rescuers had to swim the adults out. And the adults freaked out, and they only were underwater for a couple minutes to get through that one passage. And they started pulling their scuba gear off. They started grabbing the divers. People almost died. And so there's no way that they're going to swim these kids out. So One of the divers was an anesthesiologist in Australia. Um, and they sort of realized that the oxygen levels were dropping. These kids were going to die. There was no way to get them out. So they decided that they were going to take them out with general anesthesia. So what they did is they gave them glycopyrrolate, which is a secretion drying medication. It's a lot like if you took too much Benadryl, you just get really dry. And that was to dry up all the saliva. And then they injected them with IM ketamine because, they had no way of putting them on a ventilator underwater. Like they couldn't do anything mechanical. Like the kids had to keep breathing on their own. So they came up with this idea that they would give them ketamine, and then they would put a full face mask scuba seal, like scuba mask, on them and crank it down so it was incredibly tight so it couldn't leak. And then they would put them in these gurneys, sort of like these flexible long spine boards, and they tied their hands and feet together so in case they woke up underwater, they couldn't grab anything. And that's how they got them out. They would literally inject them with ketamine, and then they would start pulling them underwater. And the whole time, they just had to assume that the kids were breathing, and they weren't vomiting into their mask. They weren't choking on their own secretions. And they would take them through these water tunnels. And then when they would get to air pockets, they would sort of just look at the kid. And if the kid started wiggling, or if it had been a certain amount of time since the last dose, the divers would open a Ziploc bag that was full of pre-filled ketamine syringes, and they would just jab them through their wetsuit and re-inject the kid and then keep swimming. And I mean, when you think about it, it's a crazy plan. Like these kids were underwater in some of these passages, they would be underwater for 45 minutes, completely anesthetized, but breathing on their own and protecting their own airway, because all they had was a scuba mask sort of crunched down over their face. And you just kind of had to take it on faith that they weren't like dying under the water. And in fact, everyone survived. They got, it's amazing. It's an amazing story. They got all 12 kids plus the coach out. Basically putting them all under general anesthesia and then dragging their bodies through these watery tunnels. It's an amazing movie. I definitely recommend watching it, but it also just shows you how amazing ketamine is. You could never give someone etomidate or Versed and then put a scuba mask on them and expect them to maintain their own airway and keep breathing, right? Like it just wouldn't happen. If you did it with Versed, they would have all died underwater. But ketamine has these amazing abilities. So let's talk a little bit more about the specifics of ketamine, so how ketamine works. And you don't necessarily have to know this to great detail to use ketamine, but I think it helps to understand the basics. So one of the things ketamine does is it directly affects the spinal cord, and it particularly affects the part of the spinal cord responsible for pain and temperature transmission. So what's interesting is it doesn't affect a lot of the other parts of the spinal cord. So the signals coming from your brain still get where they need to go, and a lot of your sort of reflexive signals are still able to move along the spinal cord. But really the pain and temperature, like the sharp pain and temperature pathways, are affected. Those pathways then go up to the middle of the brain and an area at the top, near the top of the brainstem, called the thalamus. So the thalamus is like the gateway for spinal cord signals. That's where all these spinal cord signals get distributed to other parts of the brain. And ketamine has a direct effect on inhibiting the thalamus. So it's like you shut the gateway off. Also, that gateway sends signals to the motor and sensory strips of your brain, and that's how you know what's moving and what's happening to that area of your body. It has direct effects on that. And it also has direct effects on structures that create memory. So that is how ketamine works. There's also the hemodynamics of ketamine. So in these graphs, which, I'm sorry, are not the highest quality, but basically you can see these are graphs where they administered ketamine, and you can see the arrow pointing down on each graph is the point in time at which they administered ketamine, and then you can see what happens to cardiac output, heart rate, stroke volume, arterial pressure. And generally, with ketamine, these things stay the same or they go up. So, unlike virtually every other sedating agent, you get increases in blood pressure, heart rate. I will tell you just from my experience, you will see people's heart rates jump considerably, sometimes like 80, jumping up to 120 for a minute or two while the ketamine kicks in, and then it has a tendency to settle out. The other interesting thing about ketamine is it's a powerful bronchodilator, and this is particularly important for asthma. For me, this is now the drug of choice that I use to intubate asthmatics. And in fact, I've had a lot of cases where I've had an asthmatic who's doing so badly that I have to intubate them. I push the ketamine, and they actually improve to the point where I have hesitated and ultimately decided not to intubate them because it improved their airflow. So ketamine has positive effects both hemodynamically and respiratorily. So dosing. So how do we dose ketamine? Well, it's dose dependent depending on what effect you want to get. So, we talk about it in terms of milligrams per kilo. So if you give someone like 0.1 per kilo, they're going to get a little loopy. This effect is not all that different from some, mild alcohol intoxication. And, just like alcohol intoxication, that has some pain control effects. It has some sedating effects. And so anywhere from like zero point 0.1 to 0.3, this is going to be your pain control dose. Then as you start getting up to like 0.2 to 0.5, this is your dose of abuse, right? This is your quote unquote recreational dosing. This is where all of a sudden, cats start flying around the air on pizza and everything starts blinking neon lights. Like, this is your, club rave, party level dose that people abuse ketamine for. Then as you go to the high end, so 1 to 2 megs per kilo, and it's important to say these are the IV doses. If you IM this, you have to increase the dose. We'll talk about that. But IV, if you give 1 to 2 megs per kilo IV, then you're talking general and procedural anesthesia. You can use these doses to relocate bones, intubate patients, sedate them if they're fighting the tube. The problem with dosing, and this is probably the biggest issue that we run into, is when you're in between these doses and you hit the like 0.4 to 0.8 megs per kilo dose, this is when people go insane, right? This is sort of the uncontrolled, can't feel any pain, can't be directed, the patient is going bananas. And this is what happens with PCP. Now, we're talking about ketamine, but PCP dosing works very similarly. So what happens with PCP dosing is people want to be in the fun range, like the recreational dose that we see, on Party Girl there on the left. Or they want to be in the really snowed range up on the high end. What happens, though, is sometimes you dose it in the middle. And, when you hear these stories about people on PCP going crazy, the cops can't control them. They don't feel pain. The cops shoot them 30 times and they don't stop charging at them. That's what this sort of middle ground of 0.4 to 0.8 megs per kilo does. And so what happens is that these doses, people aren't sedated enough, so they're still kind of aware and moving around, but they don't feel their arms and legs. They don't know where they are. They have sort of no perception of pain or other problems. And you can get into a fair bit of trouble with this. You can basically end up with a very uncontrolled patient. So what we're trying to do, and the way the algorithms are written, we're trying to avoid ending up in this middle area. And if we do end up in this middle area, there's a couple strategies we can use to fix it. One more thing that I'll say about dosing is how much is too much. So this is the other wonderful thing about ketamine is it is extremely hard to overdose someone to the point of toxicity. So the average lethal dose is approximately 600 milligrams per kilogram. Not total, per kilogram. So it's literally hundreds of times more than any dose that you would ever give. And so that's just a nice safety buffer. And this is one of the great things about ketamine is it's really, really hard to overdose. What often happens is we underdose and we end up putting patients in positions where we don't want them to be, like the gorilla zone up here. Now, pharmacokinetics, in terms of what's going to happen once you give the ketamine, if it's IV, the effect is very quick, usually 30 seconds. IM is usually a couple minutes. You usually start to see effects in 1 to 2 minutes. Total effect takes about 3 to 4. In terms of duration, you give it to someone IV. This says 5 to 15. I have to be honest, I've never seen it quite that short. It's usually more like 10 to 20 in my experience. If you give it IM, it tends to be a little bit longer. And then in terms of clearance, we don't have to go into painful detail about the metabolism, but the short one-liner is that it's primarily metabolized by the liver. And so that's important to know. If someone has liver disease, these effects are going to last a lot longer because they'll metabolize slower. Now, unfortunately, I don't have a video because of the way we're giving this. I would have shown a video if we were doing this live. But, what you will see when you give the ketamine. So one of the most important things you'll see is oftentimes people get this crazy nystagmus, like ping pong nystagmus. Like it's not the subtle nystagmus you see when someone's drunk. It is like back and forth all the way to the left and the right really fast. It's like those cat clocks where every time the clock ticks, the eyes move to the left and move to the right. It's like that, but a lot faster. A lot of times you'll see some chest heaving for a couple moments. It almost looks like they're in respiratory distress, but they're just kind of breathing deeply and oddly. Their SAT should not be affected by this, and it usually is pretty short. As I mentioned, heart rate tends to shoot up for a minute or two. Pressure will also often go up. And even though they will primarily protect their own airway, sometimes you do have to give people a little bit of a jaw thrust or a nasopharyngeal airway just to give them a little extra help. You also may have to suction for secretions. So they'll do a pretty good job of swallowing their own secretions, but you should be ready certainly to do some basic airway movement. You may have to adjust their position. You may have to suction a little bit. But for the most part, that's what you'll see. And this video, unfortunately, won't play in this format, but if it could, this is sort of what people look like when you give the ketamine and it's kicked in about a minute or two. They sort of stare off into space. Their eyes are probably disconjugate or crossed. They're not looking at anything. They tend to get very tearful for a few moments, so that they'll look like they're crying even though they're not. And they're usually just pretty quiet and pretty still. It's rather odd when you see it. And hopefully, if I can figure out a way to distribute a video to you, I will, because it's worth seeing. So, obviously, I love ketamine. I think it's a wonderful drug. I think from a safety profile, it has a lot of advantages for EMS and for the ER, for that matter. But there are always downsides, right, to every drug, and so we should talk about those. So things can always go wrong with ketamine. So ketamine is amazingly predictable when it's the only drug on board. The problem is, and this is going to be particularly true for behavioral health, which we're going to talk about, is you don't know what else is on board. If someone's drunk, if someone's got benzos or cocaine or something else, the effects can be a little less predictable. So even though they should not have a big drop in blood pressure, even though they should not lose their airway, these things do rarely happen. And so you should always be ready to deal with these. Now, anyone on ketamine should be on full cardiac monitoring and pulse ox, and ideally expiratory and tidal CO2 at all times. Generally, if there are some airway issues, usually a jaw thrust will fix it. But you always need to be ready to have a backup airway. You should always have, king tube, LMA, or full-on intubation equipment ready. Secretions, you definitely need to be ready to suction. Suction should be hooked up, ready to go. As we mentioned, going bananas. Like, what if the person does end up in this middle range of dosing? You gave pain control, but maybe you you mixed the dose up, or you dosed it too frequently and now their blood levels in that middle range. Or maybe they're a really big person and you underestimated their megs per kilo, and so you didn't dose them enough. Well, easy ways to fix this. If you think you underdosed, just give more ketamine. Remember, the toxic level of ketamine is so astronomically high that if you overshoot, you're going to be okay. So if you think you undershot the dose, if you underestimated their weight, you may have to give a little bit more ketamine. And this is something I would definitely, at this point, I would call med control and discuss if possible. Now, if you overshot and you don't want to give ketamine because you were not trying to achieve general anesthesia, but rather just pain control, or maybe you gave a lot of ketamine and now it's wearing off and they're kind of having a bit of what we call an emergence phenomenon, generally a little bit of Versed goes a long way. And again, these are both things that med control can help you with. But if someone's coming down off ketamine and they're getting a little bit rowdy, or if you gave a little too much with pain control and they're starting to hallucinate and kind of act goofy and getting uncontrollable, a little bit of Versed tends to work extremely well. The downside, of course, is now you're mixing Versed and ketamine, and whenever you get into polypharmacy, your risks of apnea and airway loss are higher. So you got to be very careful, and you probably want to give lower doses of Versed. And then the third thing is seizures. So seizures is very uncommon with ketamine, but do happen occasionally. You treat it the same as all other seizures. You give benzos. And again, now that they have both ketamine and benzos on board, you've got to be really careful about watching the airway and supporting hemodynamics. So, ketamine really is now in 4 protocols. It's in the general airway protocol. It's in the post-intubation protocol. It's in the pain control protocol, and it's in one of the 4 new behavioral health protocols. So let's start with airway. So I know that we do not do drug-assisted airway. However, this is a NC State protocol. I know some of you work in other locations and you may work in other places later in life. And so, I do want to go over this protocol because you should be familiar with it. And I think it's helpful for just understanding how people are thinking about the use of ketamine. So, in this protocol, if you get to a point where you're going to do some type of pharmacologically assisted intubation, you basically see there's 2 choices, right? And there's that box there that says hypoxic, hypotensive, or combative. Now, if they're not any of those things, you have the old choice, which is to use etomidate, or you can use ketamine. And again, here they're using that sedation level dose, which is 2 megs per kilo. IV, you can also give it IO. It is repeatable too. If you find that your 2 megs per kilo is not quite working, you can repeat that dose for a total of 4. But what I think is really interesting here is if they are hypoxic or hypotensive or combative, you go to the right and you see that ketamine is the only option. Ketamine is absolutely the drug of choice for those situations. And this is exactly for the hemodynamic reasons that we said. So, for example, something that happens with asthmatics a lot is if an asthmatic gets to the point where they are so critically ill they have to be intubated, they are just barely hanging on, right? They are using every muscle in their body to suck air through, the equivalent of a cocktail straw, right? They are using every accessory muscle to just get minimal air in and out, and they're still not oxygenating well doing that. The traditional way, if you gave them etomidate and then, with or without sucks, the etomidate will depress their respiratory drive, and all of a sudden they go from being kind of hypoxic to not moving any air at all. And they inevitably code. The asthmatics are famous for coding during intubation. It happens all the time because they're so on the edge, and you take away what little respiratory drive is left, and no matter how quickly you get that tube in, they just crash and burn. But if you give someone like that etomidate, the etomidate we mentioned is bronchodilatory. You often see an improvement in aeration, and more importantly, you don't knock out their respiratory drive and you intubate them while they're still breathing. And so it's a great drug for situations like that. Also, trauma, hypotension, right? If someone's hypotensive, and barely perfusing their own coronaries, the last thing you want to do is drop that pressure any further. So again, ketamine is a good choice there. And then for behavioral health emergencies, as we're going to talk about, ketamine's a good choice, particularly because it's a very predictable IM. And in a lot of those behavioral health emergencies, you're not going to have IV access. So I just wanted to touch upon that just so that you have a sense of, how people are thinking about using ketamine for intubation. Now, a place where we may very well need to use ketamine is post-intubation. So, we may intubate someone in a cardiac arrest or some other situation where it was actually very easy to intubate them. And then because we did such a great job with reoxygenating them and resuscitating them, people sometimes start to wake up, right? They start to fight the tube. And so you may need to sedate someone. And historically, that has been with Versed. And, Versed's fine. But again, I prefer ketamine. And so you see now, ketamine is now an option, and it's actually listed as the first option. So 1.5 to 2 megs per kilo. Whereas in the past, you probably would have given like 2.5 megs midazolam, up to a total of 10 megs for post-procedural, post-intubation sedation. So now ketamine is a great option. And again, particularly for someone who's post-resuscitation, because of trauma, because of medical cardiac arrest, giving them something that promotes, maintaining blood pressure and airway and breathing, spontaneous breathing is actually a very good choice. So I think it's definitely my go-to in that situation. Now, the other sort of medical scenario that we're going to talk about before we get into behavioral health that we can use ketamine for is pain control. So it's interesting. There's been a lot of research on using low-dose ketamine for pain control. And again, here we're talking the very low end of that dosing range. We're talking like about 0.1 to 0.3 megs per kilo is what you're going to be focused on for pain control. So historically, if we've had someone in moderate to severe pain and they're on the right side of this algorithm and you start to go down, depending on what your system carries, Toradol, nitrous. But, for us, really, our go-tos were morphine and fentanyl. So you still have those. But you also have this additional idea of ketamine 0.2 per kilo. Couple things about this. One is you want to infuse this very slowly, and this is perhaps one of the downsides to using this pre-hospital is, you see they actually recommend infusing it over 10 minutes. And, in the back of an ambulance manually pushing this med, that's a long time to sort of sit there and have to really slowly push this med. But it's extremely important that you push it slowly. You can get into sort of all types of issues if you push it too quick. You can oversedate them. You can knock them into that like goofy combative phase briefly. It's much, much less likely to produce seizure, as well as much less likely to cause, unwanted big spikes in blood pressure if you push it slowly. So, that's why the recommendation for pushing it slowly. Now, also because of those spikes in blood pressure, generally the contraindication, you can see that on the second page, the instructions page. You want to avoid using it in hypertensive patients, people with like intracranial or intraocular increased pressure or injuries. And you don't want to mix it with benzos, ideally, because again, the combination of ketamine and benzos, you can start getting into unpredictable respiratory depression. So that's the official sort of spiel on ketamine for pain control. I will tell you sort of unofficially my experience. And also some of the more recent research shows that ketamine on its own is probably not a great pain medication drug. unless someone has opiate tolerance. And so, this is mentioned on the second page as well. If someone's a sickle cell patient, for example, and, they're very used to being on opiates, giving them a little ketamine may be a great alternative, and they might be much more sensitive to that. I will tell you what the research supports is the idea that ketamine is probably a good add-on agent to help avoid using lots of opiates. So generally in the ER, I give an opiate first. So I'm giving morphine, Dilaudid, fentanyl. I give a decent dose of that, see if they get any pain control. If they don't get good pain control, as a second dose, you can give a low dose of ketamine. And there is some synergy that occurs between the two, and you tend to see a lot better effect when you give the ketamine as a second line agent. And so that's personally how I use it in the ER. Now, in these protocols, you can use it any way you want. You can use it as your first go-to. You can use it as a second dose, like rather than redose the opiate, you can use it as, what they call an opiate sparing agent, so that you're not giving them, higher doses of fentanyl or morphine. It's really up to you, but I personally have found it tends to work a little better if you give first dose opiate, and then if your transport is long enough and you need additional pain control, second dose of low dose ketamine. Another thing to notice is you can repeat the ketamine dose. However, very careful to not do it less than 20 minutes, and that's actually mentioned in that box on the right there. The reason you want to space it out over 20 minutes is you want a fair amount of the ketamine to wear off. Otherwise, you'll end up stacking the doses. Like if you did it 5 minutes apart and you did 2 or 3 doses, right? It says, a maximum of 3 doses. Well, if you're giving 0.2, you do that 3 times, all of a sudden their total body dose is 0.6 per kilo. Now you're into like gorilla going bananas range of dosing, right? So you don't want the level to get that high, and so that's one reason they say wait 20 minutes. You really need to wait 20 minutes to let the first dose of ketamine wear off somewhat, so that when you're giving additional, you're less likely to go into that range where the patient all of a sudden becomes completely unpredictable, confused, and uncontrollable. So those are the medical algorithms, excluding behavioral health. Those are really the medical algorithms where ketamine is used. And for us, as a sedating agent, particularly post-intubation, as a pain control agent, I think this is really going to broaden the options that we have for our patients. And I will also say, I have a feeling over the next couple years, ketamine more and more is going to become the preferred agent. I think we're going to start seeing ketamine mentioned in the asthma algorithm. I think there may be this option of sort of non-RSI intubation, meaning, not intubating with a paralytic, but just intubating with ketamine as the sole agent. And I think that will dramatically improve the safety of intubation in EMS, because if you miss the intubation, they still, in theory, will be protecting their airway and breathing spontaneously. And, right now, pretty much everywhere that Versed is used, you see ketamine as an option. But I think what will happen is over time, ketamine will really become the preferred agent for a lot of these sedation protocols. And you're going to start seeing benzos phased out. Benzos will never be taken off the truck because we'll always need them for seizure control. But I think there'll be a movement away from benzos towards ketamine in a lot of situations. So that is really all I have to say about ketamine. And unfortunately, I know because we're not doing this live, we won't be able to answer questions. And I am sure a lot of you will have questions, which, again, email, call, I hope to do CME in person very soon so that we can certainly follow up with some questions. But I want you to feel as comfortable with ketamine, how it works, the dosing levels, because once we complete this CME, ketamine will be on the trucks. We're going to make it available in the Pyxis or the Omnicell, and it'll be one of our many tools. And I think it's going to be a great addition. So thank you for listening along. That is the end of part one. But make sure to complete your CME that you also listen to part two, behavioral health.